You're in for a treat tonight. I have the pleasure of introducing Dr. Salil Khandwala. He is the Director of Advanced Urogynecology of Michigan out of Dearborn, also the Director of the BOMA FPRMS program as well. So Dr. Khandwala, we really appreciate you taking some time this evening to talk about some of the key issues that women are facing every single day, as you well know. So I'll turn it over to you, and thank you so much.
Thank you. Thank you so much for introducing me, Christy, and good evening, ladies and maybe gentlemen. Some gentlemen may be there, but more than welcome. So let's talk about this issue. What is this problem of incontinence? And as you can see, the talks that, let me see if I can go back here for a second. I should be able to. Over here. So the points that we'll be discussing today are these issues of urine leakage. There are many aspects of the female pelvic floor conditions which involve the bladder, the bowel, the vaginal activity, and the vaginal prolapse, then pelvic pain and menopausal conditions. But today we'll be specifically discussing two conditions, which is the urine leakage and the bowel leakage. And these are very, very common. 1 in 2 women experience urine leakage, 1 in 2. And it's probably a high prevalence of fecal and bowel leakage also. We don't know. We have some numbers, but we may be just looking at the tip of the iceberg. What is the actual number of women who have this? Could be astronomically high. Then you put in vaginal prolapse when things start falling outside, and then bladder pain conditions, and of course, menopause that happens to all of us after a certain age. In men, it's called menopause. And so even men go through it, but they have probably different reactions, you know? So the key is this urinary leakage. It affects a lot of things. It affects a woman's ability to carry out routine activities, cannot leave the house because of the leakage, stops engaging in sexual activity that she wants to do. She wants to enjoy. She enjoys sexual activity, but cannot because of the fear of incontinence. And she's made fun of by folks around her, you know, for a medical condition. Oh, she's in the bathroom all the time. Whenever you see her, where is she? She's in the bathroom. You know, the kids are making fun. Oh, look, mom, she just leaked in her, peed in her pants. And wearing a pad 24/7. Who wants to wear a pad all the time? Sometimes, despite the pad, she may leak onto the bed sheets at night, and there may be a trail of urine left behind as she is rushing to the bathroom. For a medical condition, you cannot be made fun of, and one should not feel embarrassed dealing with a medical condition. Do I feel embarrassed if I have high blood pressure? Oh no, I'm so shy to talk about it. No. Similarly, we are made to think that this is an embarrassing condition where it is not. It has stigmatized into an embarrassing condition. It is an absolute medical condition recognized by the medical world as a condition that is a health care impairment. It doesn't let a woman socialize because she may think that she's smelling of urine, stops visiting close family. Mother doesn't want to go to daughter's house or a son's house because they don't want to leave that trail of urine behind as they're going to the bathroom. Do not even discuss with their spouses, married for decades, and they don't talk about it. They don't want their husbands to know that I'm dealing with this embarrassing condition, and it is not. And they start getting rash and they have irritation at the vaginal opening. It can therefore lead to isolation, strain marital relationships, lead to depression, affect a woman's quality of life significantly to the point that a patient of mine told me, I know leakage is not as deadly as cancer, but it has taken my life and desire to live. You know, what's the point living a physical life without the satisfaction and the quality of living that life? Are there no solution then? Do women have to suffer in silence and deal with this? Do the available solutions even work? Are the solutions so radical or fraught with complications that I better not get into them? So is it even worth getting treated, or are pads the only solution? Because the treatment is not, so women feel treatment doesn't exist, Or we'll talk about today is, are treatments so radical? So as we mentioned, it's very, very common. 1 in 3 women are affected by this, and women just are resigned to pads. And even if they go to a healthcare provider, even if they go to a doctor, they're told, well, go and do Kegel exercises. You are too young to have surgery. Why do you want surgery? Surgery may not work that long. It may just work for a few years. You just wait a little longer and then you can have it afterwards. And the present surgeries may be having complications. And here, take this pill. I have a sample, take this pill. Not knowing that this pill may not work for that particular condition. So unfortunately, we as healthcare providers also are ignorant, probably as ignorant as our patients. I'm not kidding when I say that. There are a lot of doctors who you see, like your primary care physicians, even sometimes OB/GYNs, who do not know what is happening in the field of urogynecology, especially urine leakage, bowel leakage. Tremendous strides have been made, and I'll talk about it. And even the doctors don't want to talk about it. So the patient comes in, she says, I don't want to talk about urine leakage, or I don't want to talk about bowel leakage. And why am I talking about this to my doctor who is managing my blood pressure, or to my doctor who basically takes care of my diabetes? What will he know about urine leakage or bowel leakage? So should I even bring it up? So neither is the patient bringing it up, nor is the doctor bringing it up. So nobody's talking about it, but it is something which is huge, like the elephant in the room. Pads, really? Pads? I mean, why is she laughing? Is something really to be excited about, wearing pads? Absolutely not. And they come up with these different designs and flowers, and it's super absorbent. You're really want to replace your underwear with a pad. Forget about the cost, but just who wants to wear a pad? No woman wants to wear a pad if there is a solution that they know that works. And we'll talk about that. Stress incontinence. What is that? That's one type of leakage. Let me see if I can play this. Probably not, but that's okay. The time so stress incontinence, what she was talking about, how much it affects with laughing, coughing, sneezing, how much it affects her quality of life. This is a woman standing up, the front, the back, the top, the bottom. You have the bladder here, the urethra, the vagina, the uterus, and the rectum at the back. So what happens is this urethra is the tube that brings the urine from the bladder to the outside. And when she coughs, it's not supposed to fall back. But if it drops back because there is lack of support and it falls back, urine leaks out. That's classic stress incontinence. Pads are bad because they are not only are they not the solution, but actually they hurt the pelvic floor. Why? Because once you rely on the pad, it becomes a crutch. And when you rely on the pad, then the muscles get weaker and the pelvic floor gets weaker and the control is even lesser. They hide the condition. They do not correct the condition. It's just, oh, I'm not leaking out anymore. Well, because the pad is catching it. The leakage is still happening. The disease is still ongoing. Pads are just hiding it. And they come up with these super absorbent pads and all that. That is not a solution. It is simply putting a Band-Aid on an open fracture. Constantly wearing the pad changes the microenvironment of the vagina and can cause vaginal issues. And pads cause irritation. And leave alone the cost. It's not cheap to buy pads. And then women become graduates. They go from small panty liners to pads to super absorbent pads, and then they start wearing these pull-up diapers. Really? Absolutely not the solution. They take away, even during intercourse. I mean, do you really want to be wearing a pad and taking it out during intercourse? Make a woman feel much older, and of course the cost. Not at all a solution. There's a lot that we can do. We have got away from what is called bladder suspension. We're no longer suspending anything. We do these sling procedures. These were the long sling, but now I do a simple sling where I make a small little incision, just fingernail-like incision inside the vagina. And through that, completely under local, we place a sling that attaches to the inside muscles. It's all done from inside the vagina. Now this blue thing provides a backstop for the urethra, and there is no leakage. That's how the sling works. And my technique, called the DIST technique, which I'll elaborate in the next webinar a little bit more, that is where I can actually have the patient stand up during the procedure. She's completely awake, and we can confirm that she's not leaking a drop. And we've worked on this. Patients are fully awake. It just takes 1 hour, and they're back to work the next day. What do you want to do? Want to go to work? Go to work. Want to go to the gym? You can go to the gym. There is no restriction whatsoever after this procedure. We've published our results in several papers that we're now publishing in another result where we did this in the office and followed them up for 3 years. Very high success. We have almost 100% incidence of success, or 100% cure rate, with almost 0% risk of complications. So it's very low. Rate of success is as high as 100%. When you look at the other surgeons reporting it, it's 45 to 78%. And you will ask, why is your success so high? Because we check it right there and then. Nothing is left to chance. She's standing up with a full bladder, and we confirm that she does not leave the room until she is dry. Stress incontinence, that is coughing, laughing, sneezing, leakage, very common problem, not that hard to take care of. Overactive bladder, gotta go problem. That's the other type of leakage. When patients, it just comes out. Look at this. 1 second she's dry, the other moment she's completely wet, completely. Stress incontinence, it may be a squirt comes out, but overactivity of the bladder or urgency leakage, it soaks right through. I mean, can you imagine you're standing somewhere at a function? I'm standing talking to you right now, and boom, suddenly my pants are wet. And how distressing that can be. How do you manage that? It's a huge problem in women. Again, very common, but there's a lot of things that you can do. You can avoid bladder irritants such as caffeinated beverages, go to the bathroom frequently, do the pelvic floor muscle exercises. That is the basic thing that we do. So what we do for you is we make the right diagnosis, make sure that it is correctly the diagnosis, then start you on behavioral modification, what I just mentioned, the diet, going to the bathroom every 2 hours, making sure you do your pelvic floor exercises with a physical therapist or on your own. Then there could be one medication. There's a whole family of medications we can try, another list of drugs. Then if it is still ongoing, then there are so many other procedures that can be done to help this. So look at this, how many options are available, right from fluid management, timed voiding, pelvic floor therapy, whole list of one list of drugs, the other list of drugs, and then 1, 2, 3. So solutions abound. Stress incontinence I talked about before, coughing, laughing, sneezing, done. We do the procedure, it's over. Outpatient, completely awake, no pain after the surgery, or that's why I call it procedure. Going home within an hour, back to work the next day. I mean, can you imagine? It's done. It's over. Next cough, you are dry. Solution, right? Very high. I told you almost 100% success. Overactive bladder. Look at this. With gotta go. If I have urgency leakage and I cannot make it, should I wear a pad? When I have these solutions, 1, 2, 3, 4, 5, 6, 7, and more. Fantastic solutions available. Why would you wear a pad? So we do this full evaluation, do the behavioral modification, talked about the medications. Now let's talk about advanced therapies. When medications don't work, what can be done? Remember this. We show our patients this whole chart. So you know that if 1 doesn't work, there's 2. 2 doesn't work, there is 3, and so on. So we don't stop until it works. Now, sometimes it's not that from 1 you go to 2, then 2 you go to 3. Sometimes you go from, let's say we do this inner stim, then we do that along with the medication, and that might help togetherness. So it's combinations also have to be considered. So clearly, a lot of things that can be done. Inner stim can be done in the office. So this is a patient who comes in who has urgency leakage, and she has tried medications, done her behavioral therapy, still having the leakage. It's very common. 65% of women who have overactivity of the bladder, remember 65%, they will continue to suffer in silence. and suffer in silence. So it's not that the problem is taken care of. They're still suffering in silence. Why? I mean, would you not wonder why? 65%, almost 2/3 of women will just wait it out after seeing a doctor. This is after coming to see a doctor like me, they will still say, oh, I'll just wear a pad. Why? Because sometimes they're not educated as to what all can be done. Sometimes a medication may not work, but then there's something else that can be done. They don't know. If you show them the whole chart, they know. Number 3, they may have side effects from the medication. And then, you know what, I can't take it. My mouth is too dry. Well, but there is something else that can be done. Or the cost of the medication may be too much, but there's something else that can be done. So that is what is important to understand, that there are so many options that you cannot give up. If a woman or a friend or whoever you talk to is suffering from this, we need to make sure that this is addressed. A patient who comes in, let's look how simple and straightforward this is. She has failed medications. She comes in. We do this procedure completely through the skin. So this part, as you're saying, it's done right through the skin. It's a small little, tiny little electrode that goes in. It's so tiny, you can barely see it. It goes in and right from the skin, there's no cutting involved. And that is the first step. It's called therapeutic trial. And we can see how it does. You go home and you say, wow, this has helped me a lot. Then we go in and do the second part and then place the battery in. So clearly, InterStim can be done in the doctor's office. And then if it's successful, when we go to an operating room to place it, it is done under sedation, like a colonoscopy, just you're asleep. We do it typically in my hands. It takes me about 20 minutes to perform this, and you're home within the hour. Done. Overactive bladder significantly improved. So that's one aspect. The Botox, that also can be done in the office. You have little injections of this Botox in the bladder. That takes a few minutes, and it basically creates like hurdles for the electrical impulse to go through. And now it prevents this bladder contraction from happening, and overactivity of the bladder is improved. Similar to that is a leg stimulation. So this leg stimulation is a small acupuncture-like needle that's placed here in the office. And literally, she's reading a magazine as we're doing this in our book. It takes about half an hour or an hour for her to be in the office. It's done, and then she is home. Has to come in weekly to do this, but overall, it's still successful. So I showed you 3 things that is secondary. So after medications have failed, after pelvic floor therapy has failed, after your behavioral therapy has failed, 3 solutions. None of these solutions involves cutting open the abdomen or hospitalizations. These are all done in a doctor's office or an outpatient surgical center. Can you imagine? That's how much overactive bladder management has evolved. Now we are also doing an implantable tibial nerve stimulator that I was the first person in the world to do this procedure. And it involves a small lead that is placed in the medial part, the inside part of the leg. And that goes and stays in the inside part of the leg with its own battery that's right here through a tiny incision in the leg. That's how this is performed. It is a clinical trial that we are doing. And if that has become successful, then we have even one more option. Bottom line, all this can be done in the office or an outpatient center. There is really no downtime from work at all. No pain or minimal discomfort, if anything. So let me ask you this. I've showed you these both conditions, stress incontinence and urgency incontinence. I've told you the solutions and how straightforward these are. Then why should or would a woman continue to wear pads? So now if I go back and ask you, maybe you can tell me when we break out at the breakout session, is why is a woman wearing a pad today? Because she does not know this. Once women understand the different options available for them, who would want to wear a pad? They want the treatment yesterday, not even today, yesterday. So I was giving a talk like this once, and it was an open auditorium pre-COVID. And someone stood up and said, what are you doing this afternoon? People don't want to wait. Once it's done, fix me, get it done, it's over. So clearly, there is no reason to continue to leak. There are solutions which are very successful. So to answer those questions I posed earlier, do the available solutions even work? Yes, they do. Very, very high success rates. Are the solutions so radical or fraught with complications? No, I showed you. This is all done with the patient awake, either in a doctor's office or outpatient surgery center, and they're back to work the next day. It's like one of my patients said, it looks like a drive-by procedure, like McDonald's. Is it even worth getting treated, or are pads the only solution? Pads, never the solution. With that high success rate, with 85% of women with overactive bladder noticing at least 50% improvement in their symptoms with the advanced therapies, why would a woman wait? There are such good solutions available to them. Well, skip bladder pain syndrome is when there is discomfort, but let's talk a little bit about bowel leakage. Bowel leakage is not uncommon, and it's not only about the older women. Yes, we may see them more in nursing home patients, but this could happen to young women after one child. They may not have actual leakage, but they may have to rush to the bathroom because if they don't get there, it may start coming out. So it's not uncommon. So half of the residents in nursing home have this. Is one of the reasons for urinary tract infections is bowel leakage, and also a reason why women stop mingling socially. I mean, you don't know what's in your pad. When you go to the bathroom and check it and you see a little stool sitting there, I mean, can you imagine how disrupting it is to your morale that I just had a bowel movement and I did not even notice it, did not even feel it, it just fell out? And is it her problem? No, it can happen for multiple reasons, and we'll talk about that. It's 8 times more in women than in men, and not only a problem of the old, it can happen in the young too. And most cases can be completely corrected or significantly improved, similarly as an outpatient setting. Pads are not the solution. I was talking to a patient just yesterday, and I was telling her, why are you wearing a pad if you don't have urine leakage? At least at home, try not to wear a pad. We've taken care of the urine leakage now, so why are you wearing it? And first, I thought she would say, oh, yeah, because it's security blanket. I said, yeah, but at home, just don't wear it. So at least you'll save the cost. And then she told me, well, it's not really for the urine. You fix that problem. But now I have my bowels, I leak bowels sometimes. And I told her, you never told me this. I take care of that too. And she said, yeah, I should have told you that, And well, she finally told us, and now we'll take care of that. Very embarrassing bowel leakage, very debilitating. Who wants to leak stools? It's a huge problem. Why does it happen? So this is your bowel. The large bowel starts from here, which is on your right side. It goes to the top, comes to the left side, and then it opens down at the anus or the anal canal. So there's a muscle around it that keeps it nice and strong at the end. Why does it happen? Well, this is one of the most common causes, childbirth. As the baby's coming out, it spreads that muscles apart, it tears the muscle, and that can cause it. Sometimes hemorrhoid surgery can cause it, and constipation also, because when you're backed up, it can put so much pressure on the muscles that it can weaken it and cause leakage. So we give the patients a stool score. This is type 1 Bristol score, where it's complete pebbles to mush. So we mush, if I have food poisoning, any one of us has food poisoning, we may leak a little bit of stool because that's it. It's going so fast. So if it's mush, we want to our goal is to get to 4. So then we do something to get to 4. And if it's this, we want to get to 4. So how do we do that? That's important to improve the stool consistency. For example, if there's a bowel that's bulging up into the vagina, that can worsen the constipation and can cause leakage. So fixing this bowel bulge called a rectocele may make sense also. If there's a rectal prolapse that's falling out of the rectum, that also can cause the bowel leakage. And this is the weakness. You can see normally the perineum, the area between the vagina and the anus, is quite well defined. In this case, it's very shallow. And you can see almost the sphincter is pulled away. You see these creases? The creases don't start until here. That means, the sphincter is no longer up here. There are no creases up here. That's called a dovetail sign. There are no creases in the front, and that's why there is weakness. So we do a test called the pressure recording, like a blood pressure recording of the anal sphincter. And that tells us exactly how strong or the weak the sphincter is. And then we do a 3D ultrasound to see, is the sphincter intact or is it disrupted? As you can see, that lady that I showed you with the dovetail, you can see the sphincter is from here to here, and there is no sphincter in the front. This is black, is no muscle. It's torn. And because if it's torn and spread open, it can't constrict around it. What can be done? First and foremost, the same simple things, diet and exercise. If she's constipated, relieve the constipation. If she has mush and loose stools, get them to be well formed. And there we go with different aspects to improve that. Then avoiding irritants to the bowel. And at the same time, if she has loose stools, giving Imodium or loperamide to get them to become firmer, like that level 4 stool area. Then if the muscle is torn but not completely, strengthening them with physical therapy with our physical therapist would also help with that. And that's done in the office. Literally half an hour time spending with the physical therapist on a weekly basis or twice a week basis can help significantly. And that is what we do. We have the patient squeeze, and then the green part is where we stimulate those muscles to get stronger. And if this is torn, it could be repaired, but that's not so successful as is InterStim. InterStim, like what I showed you before for the bladder, can also help for the bowel. So it helps both the bladder and the bowel. So if a patient has both urine leakage and bowel leakage, InterStim is very well suited. The beauty of this battery is it's a very small battery. You could use a smaller battery that is rechargeable battery, and this could last almost 20 years. So think about it. You have a procedure done. It takes about half an hour to perform in an outpatient center. You go home and you could be good for 20 years. I mean, that is something, one procedure and you are done. We go through big operations and still we suffer from issues. Here, it could completely change a woman's life when it comes to bowel leakage. Now we can even do it with if a patient needs an MRI. So it's an MRI compatible. It has been approved by the FDA. Success, as I mentioned, 85% of women will have at least 50% improvement in their symptoms. Of course, you've got to do everything else. You've got to make sure that you're eating correct, taking your probiotics, and keeping the stool's proper consistency. Bowel leakage is a huge problem. It's easy to diagnose. It can be controlled with just sometimes dietarily or pelvic muscle exercises, and then you have procedures to help it. So now that said, I told you 1 in 2 women suffer from these conditions. Where you talk about urine leakage because of coughing, laughing, sneezing, or if you talk about from urgency leakage or bowel leakage, look at the solutions. I never mentioned one time patient got hospitalized. She had to be cut open. She needed to be out of work for 4 weeks or 6 weeks. Gone are those days. For the last decade, ladies and gentlemen, last decade, we have been doing this in an office-based procedure or outpatient. So you're wondering, last decade? Does it really mean decade? Is that 10 years? Do you know decade is 10 years, Dr. Khandwala? Yes, 10 years. At least 10 years, we've had this solution. 1990 was when the first sling was devised. 1990. Same thing with InterStim. InterStim has been around for 20 years and has been approved for urinary leakage and then bowel leakage. So if it's been approved, you're perplexed and thinking, why does my doctor not know about this? Well, because they're managing high blood pressure. They're managing diabetes. They're not managing this issue, sadly. We are now doing these webinars, just like how I'm doing for you. I'm doing that for my colleagues and teaching them different language, statistics more, more medicalese, but talking to them and telling them, guys, look, and they love that because they want to know more about it. So this is not something that is not treatable. And what we do is we track our patients. We publish our results. We have a fellowship, and Dr. Baratono may be joining me soon, and we innovate. And that's why we do these unique procedures like standing. So when Tom Cruise says this, show me the evidence. Show me the evidence. So when my patients ask me, show me the evidence, doctor, what is the success? We can tell them, look, this is a success. This is how low the risk of complications is. This is how quickly you can bounce back and you're back to normal activity. You want to wear pads now? Stay dry, be dry. All right, let's open it up.
Awesome. Thank you, Dr. Khandwala. That was just an amazing amount of information. I think it's super helpful to hear the explanation. And I think the resounding message is pads are not the solution, right?
Yep.
So I'm going to go ahead and look here at the questions, and let's see if I'll give some folks a minute to type some questions in. One question that just came in was about insurance in these procedures. Are these covered primarily? Can you talk to that a little bit, please?
This is a medical condition like heart attack, heart disease, like a bypass surgery. All that is covered, right? Similarly, this is an absolute, there's a CPT code, there's an ICD-10 diagnosis. So this is absolutely covered by the health insurances and medically covered. So it is a medical disease. This has got nothing to do with cosmesis.
Great, thank you.
Yep.
Another question is, I've tried medications in the past and couldn't stand the side effects. Like, how do I know what to do next?
Yep. That's a very good question. See, medications, there's some issues. Medications, they go throughout your body. So a lot is changing in our field, not my field of medicine, where a lot is going away from drugs and drug therapy to electrical stimulation and targeted therapy. So electrical stimulation is more localized. In one area, a drug goes all over your body. So it can affect different areas of the body. For example, when you take a medication, it can affect the tube that brings the saliva in the mouth from the gland that resides at the back of the jaw. So if that tube slows down, the saliva doesn't come in the mouth and you cannot talk because there's no saliva in the mouth. So that's a big side effect of drugs. Patients tell me, it worked great. I can't even open my mouth and I can't talk. It's like dry. Then if I've got cavities, they'll worsen my cavities. My dentist is getting mad with me because I'm getting more cavities because I don't have the saliva coming in mouth and taking care of it with its bacteriostatic properties. So yes, that could be an issue. Patients who have constipation, that could be an issue. The third major issue of these anticholinergic medications, the main prevalent drug is what's called anticholinergic cognitive burden. What that means is it can affect cognition. It can affect your mind. And patients who have a strong family history of dementia, we do not want to give them because it can cross the blood-brain barrier. It can affect it. So drugs have side effects. Drugs can also be costly. Whereas when you go with procedures, these are more localized. Like if you do the inner stem, it's affecting right there, the S3 nerve. It's not going all over the body. It's not sending electrical activities across the entire body. So because it's so localized, it affects that area and therefore it is more targeted. So it does not have the side effects of a medication. So initially, intuitively, it makes sense that, okay, if I can be on a drug, I can pop a pill, doctor writes a prescription, fill it in the pharmacy, pop a pill, I'm home. So it doesn't look that concerning. Whereas, I've got to have a procedure, something in my back, is that a problem? First of all, it's not in the back. So let's get that very clear. The inner stem does not go in the back. It goes in the butt. When people say back, they think the spinal cord, or the vertebral column. Nope, it doesn't go there. It goes way, way below. Then the spinal cord is ended way above. So it's in the buttocks. It's not in the back. So let's get that one fact very, very clear. Number two is, yes, it's a procedure. But if a procedure by itself can sustain for 20 years without you having to do anything more, well, isn't that much better than popping a pill every day and potential risks of the pill? So we have to weigh that, pros and cons of drugs versus not. Yes, right now, the typical course of action is medications, and then medications fail. We go to these procedures, but soon, I'm telling you this, it's coming with this gray zone where it's up to the doctor to decide what is the best thing for this patient. I have a lot of patients who come in with polypharmacy. I mean, they're literally a pharmacy. They are taking so many medications that they can say, hey, you want to get a pharma? I have everything. What do you want? So they have diabetes medication, high blood pressure, cholesterol medication, so many drugs they're taking. They don't want to take one more drug to add on to it. And then I'm confused because now they're on these new drugs. I don't even know what these new drugs are. I said, what is that? And so then should I give this drug? Should I give this? What is the reaction to that? Or what happens? So there's a lot of this confusion. And some people have renal issues. The drug may not get excreted. So there are many things that we have to watch out for when giving a medication. So when you look at a procedure, it is very straightforward, whether it's Botox, whether it's InterStim or the leg stimulation, they're very straightforward because it's a targeted procedure. So I'm hoping that in the near future, we can come up with this blended zone where a doctor can choose what is right for the patient after, of course, after she has claimed ownership. You don't claim ownership for your health, I'm not going to help you. And I should not be helping. You must claim ownership. You must watch the videos that we put on our website. You must understand the disease state. You must understand why it happens, and I'll help you do that. And you must make modifications in your diet. You're guzzling water and coffee, Coke. Forget about it. There's nothing I can do about it. You've got to take that ownership. You've got to go to the bathroom every 2 hours. You've got to keep those muscles tightened up. 3 minutes in a day. 3 minutes, you cannot tell me you don't have 3 minutes. And then I can help you a lot. So you take ownership first, then we can do so much for you.
Excellent. Thank you. Dr. K, you just mentioned the videos on your website. When we send out this recording, we'll certainly send the link for the website too. If you want to mention, some of what you have on there, I think that would be great.
Yeah. So the website is www.augm, and we'll send that to you. It's Advanced Urogynecology of Michigan, augm.org. And they're free webinars. They are educational seminars available to any and every woman. You can disseminate, whoever can watch it. It'll have a disclaimer because it's on YouTube. So they'll say, you have to be at this age. Just say, okay, yeah, I'm just like older, the age, it's age appropriate because of some information on it. But if you guys can, of course, watch it. When you watch it, you will see my patients love that information because it'll give you so much information, give you so much education that what can be done, for these conditions. And when you go, and some of my patients literally go binge, like how you like binge watching, on Netflix. Some of them literally go binge watching, and I ask them, "Did you watch what you're supposed to watch?" And they tell me, "I watched everything." I said, "What do you mean everything?" So I watched all the videos that you have. So what are you talking about? So why'd you watch everything? She said, "Oh, that's great stuff, And we are creating that. We are working on our educational seminars. We are linking them up so a patient can actually see, okay, I can go from here to here to here. So we are improving it a little bit more, but the information is a lot there. So once you are educated, you have to really tell me this, because that is something which I don't think I know the answer, and I'm sure I'm correct, that a woman is once educated, because I see them all the time. Once she knows the information, she knows what can be done. She is aware of the risks, benefits of the procedure. She's aware of the success of the procedure. She's aware how simply the procedure can be performed. There is no way she's going to be wearing pads. No way. I have never had a patient come and say, "Thank you so much for all this fantastic information. I love my pads." Not a single one. They'll take the pads and put them in what we call our pad burning party. So burn them.
We had another one that came in, and then we'll just see if there's one more. But will removal of the gallbladder bring on bowel leakage?
It could. Different type. Removal of the gallbladder takes away gallbladder. Bladder is a storage. Bladder is a Latin word for storage. So the storage of the bile acids is gone. So the bile acids from the liver go straight into the bowel. And that can, the moment you eat something, it can stimulate the gut and make you run to the bathroom. Different problem, has got nothing to do with the sphincter. The InterStim is not going to work for that. For that, you have to see a GI doctor, and they'll give you something called cholestyramine, and that will help bind the bile acids and prevent that from happening. Totally different problem. One thing I must emphasize that, and I see patients and they'll ask me time and time again, sometimes I'm also remiss, I don't give that sometimes right answer, because the right answer nobody wants to hear. And it could very well be the weight. They are morbidly obese, and that is a very, very important factor. Weight is so important. Eating right, losing weight, keeping a BMI correct, That is so important. Just by doing certain things like that can completely change the dynamics of healthcare. Your overactive bladder is gone. Stress incontinence is gone. Even bowel leakage can be restored. But that said, even in healthy, well, strong women, they can still, who love to do jumping jacks, they cannot do it because it's a medical condition. Just one child can make a little change in the pelvic floor that can result in incontinence. So even if it happens and you say, I'm so fit, I go to the gym all the time, look at my abs, I've got a six-pack, I'm so strong. Well, it doesn't matter. It can still happen. And there is solution. The solutions now. And that is very important to understand that there is really not a single solution that talks about admission to the hospital. I used to go to the hospital as a doctor. I used to go to the hospital when I was a resident and then a fellow all the time. We would go in and round on the patients and do everything. Now I rarely go inside the hospital. I'm out doing surgeries in my outpatient OR, go to the OR to do the operations. Even if I do my large prolapse cases, patients are going home the next morning. I do not even go back. I never go onto the floors. The leakage issues are either done in the office or in an outpatient center. You don't even go to the hospital. Can you imagine how much things have changed? And you're back to work the next day. So I cannot emphasize enough how straightforward these procedures have become. The management has become. Once we swiftly, in a matter of 20 minutes, swiftly make a diagnosis, an accurate diagnosis of a condition, 20 minutes, we listen to the history, do the exam, do the appropriate test, and we have the diagnosis. Once we have the diagnosis, we institute the treatment. By next week, you are dry. I had a patient who came to see me. I'll end on this note. I had a patient who came to see me yesterday or Monday. We had a very busy 2 days. On Monday, we had a patient. She came and saw me. And, she told me she was, I think, in her early 60s. Yes, she was, yeah, because she is in her 60s, because she and her primary care doctor, she told me, have the same age. And her son, her kids, are in the 30s. She told me that she has had incontinence since the birth of her first child. And just think about this. 30 years she has had incontinence. 30 years. Isn't that sad?
Yeah, it's amazing, how long some folks really do suffer. One last question, Dr. K, was about accidental gas. Put in here, can't control the gas, super embarrassing. What do you recommend? Come in.
I recommend that you should not go to a yoga class and go in a boat pose because it's a very quiet room. I'm kidding. So I teach yoga. I'm a yoga instructor, So in fact, I teach something else. So I teach a pose that allows them to basically release gas. It's a release gas pose because constipation is a huge problem, and it's called Pavanamuktasana. Really, the pose is called release the gas pose. And it's not what your answer is, but I'm coming to that. So that is a big problem. When you have gas buildup and constipation because of that, it can cause an acute emergency. You're going to the hospital with severe pain, and all it is you're constipated and with massive gas backing up. Different problem. What you're saying is if gas leakage happens, yes, our rectal sphincter that I just showed you back there, it's such a fantastic organ. This sphincter right here, this muscle, is fantastic. Can you imagine? Let me have you put up your hand. If I put some liquid and solid in your hand and just let the liquid go and not the solid, you can't do it. If I say, okay, I've got something solid in your hand, can you let the air go and not the solid? You can't do it. Whereas we can do it. We as humans can pass gas and not pass stools. Can you imagine how good our sphincter is? It'll let the gas go out, but not the stools, not liquid stools or solid stools. But sometimes because the sphincter gets a little weak, the gas comes out, or you're producing a lot of gas because of constipation. And if there's too much gas production, then it can come out more than otherwise, or it could just be a weak sphincter. So it could be two factors. Number one, excessive production of gas which could be some GI issue, some malabsorption issue, which is one. Number two, constipation that causes more gas production. Or number three, the end sphincter is just not tight enough. That's preventing that gas from staying in, and it just loses it. Like you bend out, it comes out. So those are the three factors. So we got to look at all the three factors, and many a time strengthening the pelvic floor, probiotics, improving the GI tract, and avoiding constipation. So there's a whole concept that you have to consider, just not, oh, let's just do surgery.
Absolutely. Well, thank you, Dr. Khandwala. That's it on the questions.
Yep.
Again, thank you for your time. And
I'll just end on one key note. To summarize this, 1 in 2 women are suffering from this. I mean, just think about it. And I'm not making this up. Every statistic says 1 in 2 women suffer from this. Then you have to really ask yourself, I'm not that, when am I going to be the 1 in 2? But you have to ask yourself and tell yourself that, look, someone in my family is suffering from this. I need to share this information with all the women that I know, all women. You have to become the ambassadors, and that's our goal. I can't do this alone. I have a busy, you have no idea. I literally jumped onto the call and I was doing something else before that. And I cannot do it alone. I need your assistance, and you have to be ambassadors, and you have to share this knowledge and give it to someone else and someone else. So every woman knows what the solution is. So they need to know, our goal is that every woman should know, number one, this is a medical condition, whether it's urine or bowel leakage or prolapse or whatever it is. It is a medical condition, number one. Number two, there is diagnosis and can be made very quickly. Number three, there are fantastic solutions that are available with extremely, extremely high success rates, with extremely low complication rates. Number four, most of these can be done in a doctor's office. Number five, I know where I can review and watch this information. I could go to Khandwala's website, go there, I have the information. Number six, now I got to find a doctor in my area who I can link. I know the solution, I know what it is. Now I can ask my doctor, Dr. Smith, do you do this procedure? Can you do this and help me? I'm not even asking you to make the diagnosis. I've already gone beyond that. I know what can be done. Can you do it for me? Oh, why don't you do Kegel exercises? I'm going to find another doctor. Don't ever suffer in silence.
Wonderful. Thank you so much, Dr. Khandwala, for your time. And we'll certainly get this recording out and the link to the website and all that as well.
Take care, guys. Bye. Thank you.
Thank you.